Hello, my name is Daniel Kent. For my pediatric pharmacotherapy rotation in service, I will be talking about early caffeine use in the neonatal intensive care unit. I chose this topic because I was on rounds in the ICU earlier in the rotation and I had seen patients that were on caffeine. However, I was unsure as to when the best time to start a premature infant on caffeine was. So, with all that being said, and without further ado, let's get into it. So before we start, I just want to outline the learning objectives for today's in-service. You should be able to list the therapeutic effects of caffeine citrate in preterm infants. You should also be able to describe the mechanism by which caffeine citrate exerts those therapeutic effects. And lastly, you should be able to describe the benefits of early initiation of caffeine in preterm infants. To give a little background about the topic, caffeine citrate is a very commonly used medication in preterm infants in the neonatal intensive care unit. I would venture to say it might be the single most common medication used for preemies. It has both intravenous and oral dosage forms, and by oral route, that's going to be either through an NG or OG tube, as these kids aren't able to eat on their own. It's used to treat apnea of prematurity and is also used to facilitate weaning off mechanical ventilation. As far as clinical effects go, it causes CNS stimulation. It also stimulates inspiratory drive and improves contractility of the diaphragm. To summarize those three things, I like to say that caffeine pretty much just reminds these babies' brains that they need to breathe and makes it easier for them to do so. You might be thinking, well, do these babies just stay on caffeine forever? When do we discontinue it? No, caffeine is usually discontinued at 34 weeks, corrected gestational age, due to the lack of evidence on benefit past that point. Here is a figure that I think illustrates pretty well how caffeine exerts those effects that we talked about earlier. The primary mechanism is through inhibition of phosphodiesterase, or PDE, which is right there in the middle of the screen. Caffeine inhibits it, and PDE is the enzyme that breaks down cyclic AMP. So this leads to an increased level of circulating cAMP. It's also been postulated that the prevention of apnea may occur by competitive inhibition of the adenosine receptor. The CNS stimulant effect causes the medullary respiratory center to be more sensitive to carbon dioxide, which thereby increases the respiratory drive for these patients. And that's the effect that we want for these kids because they're having apnea of prematurity due to, well, being premature. It's been demonstrated that caffeine can decrease the incidence of one, bronchopulmonary dysplasia, which is a disease caused by prolonged mechanical ventilation and/or high-flow oxygen therapy in premature infants. Caffeine reduces the time required on mechanical ventilation or high-flow oxygen therapy and therefore reduces the incidence of BPD. It's also been shown to improve neurological outcomes and reduce the incidence of both cerebral palsy and cognitive delay. This is likely due to the increased cerebral blood flow caused by caffeine. As far as dosing goes, typically a 20 milligram per kilogram loading dose is given to these preemies, followed by a 5 milligram per kilogram maintenance dose every 24 hours. And then after that, the dose is titrated depending on the number of instances of apnea, bradycardia, or desaturation. So if the baby's having a lot of instances of apnea and bradycardia, then we're going to increase their dose a little bit and tailor it to their needs. Also, as a little tidbit of information that you might need, the caffeine base for caffeine citrate is half that of the caffeine citrate dosing. So now that we've talked a little bit about caffeine, a little bit of background and why we use it in these preterm infants, I want to talk about the optimal time to start caffeine for the premature infant. This study that I found was fairly recent and it was titled Systematic Review and Meta-Analysis of Clinical Outcomes of Early Caffeine Therapy in Preterm Neonates. So pretty much exactly what we're looking for. And it focused on early versus late initiation of caffeine therapy in preterm neonates specifically. I'll get into the details about what exactly the difference between early and late initiation means in the next slide. The specific goal of this analysis was to study the therapeutic outcomes of early initiation of caffeine versus late initiation of caffeine in preterm neonates. So now, to define those, early caffeine use, or ECU, was defined as initiation of caffeine less than 3 days after the patient was born, or postnatal age, whichever you want to call it. Late caffeine use, or LCU, was defined as initiation of caffeine 3 or more days after the patient was born. In order to study this, the authors did a systematic literature search in PubMed, Embase, CIN, AHL, and Central from the inception of those databases all the way until June 30th, 2016. This search brought back about 65,000 patient results through case studies, case series, cohort studies, and also randomized clinical trials. However, not everything they found was relevant to early versus late caffeine initiation in preterm neonates, so they had to narrow it down quite a bit. So the study talks a little bit about the outcomes of caffeine versus placebo. However, that's already been pretty extensively studied. So the bulk of the analysis focused on early versus late initiation of caffeine. After narrowing it down, the authors ended up focusing on 7 studies that directly compared early versus late initiation of caffeine. Of those, 5 were cohort studies and 2 were randomized clinical trials. So just to reiterate, of the 7, 5 were retrospective, 2 were prospective. After pooling the results, it was found that early caffeine use, which again is caffeine initiated less than 3 days postnatal age, reduced the incidence of bronchopulmonary dysplasia by 20% for the cohort studies and 33% in the randomized clinical trials. Both of these are statistically significant results. And furthermore, the pooled results for the early caffeine use reduced the rates of patent ductus arteriosus by 29%, excuse me, in the retrospective studies. And this result was statistically significant as well. Unfortunately, the results showed no difference for other outcomes like patent ductus arteriosus, brain injury, and death for the randomized clinical trials. I think since we already know that it's better to use caffeine than to not, the results were pretty predictable for bronchopulmonary dysplasia. However, it was surprising to see that there was no benefit in the randomized clinical trials for the other outcomes. To summarize the results of the study, the researchers concluded that early caffeine use in premature infants reduced the incidence of bronchopulmonary dysplasia when compared to late initiation in both the retrospective studies and the randomized controlled trials. The retrospective studies suggested that early caffeine use reduced the incidence of patent ductus arteriosus requiring surgery, brain injury, and it also lowered mechanical ventilation duration. It was noted, however, that the rate of PDA requiring surgery may have been biased by physicians not being as worried about it if there were less instances of apnea, bradycardia, and desaturation for the child. And finally, the randomized clinical trials showed that there was no benefit to using early caffeine for outcomes like PDA, brain injury, and death when compared to late initiation of caffeine. This concludes my presentation on early caffeine use in the neonatal intensive care unit. If anyone has any questions, you are more than welcome to email me at daniel.kent@ttuhsc.edu. Thank you.